School of Medicine at the University of Southern California and Senior Medical Director for Clinical Adoption at Cognoa. She was the 2018 President of the American Academy of Pediatrics, and her work includes integration of behavioral health and technology into primary care practice. Dr. Kraft received her BA at Virginia Tech and her MD and pediatric residency training at Virginia Commonwealth University with an MBA from the University of Cincinnati. It's my pleasure to introduce Dr. Kraft, and I'll let you take it away.
Thank you so much, John, and thank you, Pramila, for the opportunity to present here. I'm going to be talking about streamlining the current autism diagnostic pathway. Let me get my presentation up here and together. So we'll go ahead and get started. I'm representing Cognoa, which is a pediatric behavioral health company developing digital diagnostic and therapeutic solutions with the goals of enabling an equitable access to care, improving the lives of children, and really looking at those areas where access to care and quality of care is an issue, and to be able to use modern technology to improve that access and to improve that quality. Cognoa was founded in 2013, and their artificial intelligence-based technology originated with studies conducted out of both Harvard and Stanford University. Dr. Dennis Wall was the primary in all of that. I'll be talking about Canvas DX, which is actually the first marketed product that Cognoa has out there, and it gained FDA marketing authorization as a digital aid to diagnose autism in young children, and really designed for primary care practitioners. So let's get started. And John mentioned this as well too, that patient pathway from initial parent concern to the average age of diagnosis is way too long, and it's been too long for a long time. The CDC started its Act Early and Learn the Signs campaign in the early 2000s. And despite all of the awareness and all of the treatments out there and the explosion of access to resources to therapies and ABA, the average age of diagnosis has not moved the needle in 20 years. It's still at 4 years and 3 months. And we also know that the early intervention window is defined as that time frame when intervention has the greatest effect on long-term outcomes, and that's going to be between 18 months and 3.5 years. The earlier, the better for intervention. From a primary care physician perspective, this is what has always been and has always happened. And that is that child that you have seen from the time that they're a baby to an older age infant to a toddler comes in with a parent, and that parent will say, I am concerned about my child's development or about their speech or about their interactions. And what happens in the primary care space is the differential diagnosis of that concern is vast. And so what has happened over the years is that primary care has said, okay, we will refer you for that specialist evaluation. The problem is that there's a huge shortage of specialists. And so the wait to get in to see a specialist is anywhere on the average between 6 months and 18 months. And that shortage and the time-intensive evaluations are factors that result in those long wait times and delays in diagnosis. So the Canvas DX algorithm integrated that training data and clinical guidance to look at the maximally predictive features of autism spectrum disorder. Using tools that exist, such as the ADOS and the ADIR, specialists in expertise with autism specialists were consulted during the development to look at what did they can look at as and figure what were the most important aspects and the most important questions of these particular tools. And what was it that they observed in the children that were most predictive of an autism diagnosis? So the algorithm was designed with this data in mind, and it was trained on thousands of sets of young children going through that autism diagnostic process and typical children, so that the algorithm could really juxtapose what that clinical scenario was and begin to start to separate out who had autism and who did not have autism. Canvas DX is intended to aid in the autism spectrum disorder diagnosis in the primary care setting. The trial was done on children ages 18 months through 72 months at risk of developmental delay based on the concerns of a parent or a caregiver or a healthcare clinician. It is not intended to be used as a standalone diagnostic, but as an adjunct to the diagnostic process with those primary care clinicians who know that child and that family and what that child has been through throughout their life. There's no contraindications to using Canvas DX. And this is the way that it is being used and proposed being used. Canvas just launched in the beginning of November, and so we are beginning to see its use out in the field now. Your clinician prescribes Canvas DX. It is a prescription diagnostic based on a parent concern or a clinician concern for developmental delay. There are 3 inputs that go into the algorithm, and these inputs come from parents or caregivers, they come from the child themselves, and they come from the clinician. So what happens is that once the Canvas DX is approved by that child's and family's insurance company, the parents are given a link to download onto a smartphone or onto a tablet. And the first thing that they've got is a caregiver questionnaire, 18 to 21 items based on the age of the child via that mobile app. After they've answered those 18 to 21 questions, they are then prompted to upload 2 videos of their child. That first video is face-to-face, so that our video analysts who are master's degree level trained or above can look to see, does that child make eye contact? What is that child's speech like? What does that child do in terms of responding face-to-face with a caregiver? The second video is of that child in a play environment. And what's being looked at is that child doing typical play. Are they playing with a car, for example, and running it along a street? Or are they spinning the wheels and looking at it? Or are they lining up cars? So we're looking at typical versus atypical play. And in a play environment, you can look for stereotypic movements, you can look for toe walking, you can look for hand flapping. All of these things are then coded, and that becomes the second input. The third input comes from the clinician themselves, where they do a questionnaire, either in person or via telehealth, to ask specific questions based on that child's development that are somewhat focused towards autism spectrum disorder. So after the three inputs are collected, then the algorithm analyzes those inputs, and there are 3 outputs that come out. That child is positive for autism, negative for autism, or there's an indeterminate output. And that result to report is then sent to the primary care clinician, who can sit down with the family and go through some actionable items on what to do next. This is just a picture of what the caregiver mobile application and questionnaire looks like. So the questionnaires are easily answered. There's 17 to 21 of them based on the child's age. And after they answer the questionnaires, you can go on to the third screen there, where it shows the video instructions. And this is a schematic of where the output is for that primary care clinician. Remember, at that concern, traditionally, we have had this vast differential diagnosis with no way to try to figure out what's going on with that child. Instead, what Canvas does is it gives us a positive reading for some kids, a negative reading for some kids, and an indeterminate reading for some kids. Now, you will note the size of the bars on here, and it looks like indeterminate is the largest category, which in fact it is. 68% of those kids are indeterminate, but a third of the kids actually do get a positive or a negative output. And all 3 of these are actually actionable in a primary care space. I'll explain that in just a minute. But first, I'm going to talk about the Canvas DX pivotal study. This is really important to understand where the data came from, where the outcomes came from, and how we know this device could actually work as a diagnostic aid for autism in the primary care space. So the Canvas DX pivotal study was multi-site, prospective, blinded, method comparison cohort study. The primary endpoints were a positive predictive value greater than 65%, and a negative predictive value of greater than 85%. And the comparison was with a specialist evaluation. How did Canvas DX do when that child went through the process of Canvas DX and then they were seen by a specialist? The secondary endpoints were sensitivity and specificity of the device in the overall study population. There were 425 completed children in the study. They were ages 18 to 72 months, 14 sites throughout the country. And then we had central review panelists as well too, that oversaw both the Canvas clinical result and the specialist clinical result. This is just a schematic of the study flow for the device. Children were recruited when their parents expressed a concern or that healthcare clinician was concerned about their development and consented to go into the study. The first thing that happened was they underwent the Canvas DX diagnosis. And once they had an output for Canvas DX, they were then seen by a specialist. And these specialists were developmental behavioral pediatricians, they were child neurologists, they were child psychiatrists, but people who generally spent a lot of time diagnosing kids with developmental disabilities. If the Canvas DX diagnosis agreed with the specialist outcome, and a central review panelist looked and agreed with both of these things, then that study was completed for that child. If there was disagreement, if there's a disagreement between the Canvas DX outcome and the specialist outcome, if there was disagreement between both outcomes and the central review panelist, that child actually went to another special evaluation. And once all of that data was collected, the best 2 out of 3 was the result that was reported. Some of the inclusion and exclusion criteria. We needed to have caregivers who could read and understand the informed consent and have functional English capacity. There needed to be caregiver or clinician concerned for developmental delay. So this was not done on just typical children. Male or female, greater than 18 months, less than 72 months of age. Caregiver needed to have a smartphone app and internet capability to be able to download the study app. And the participants had to be willing to be videotaped during the diagnostic assessment by the specialist clinician. We specifically ruled out specific criteria, one being that that child was already diagnosed with autism. Secondly, that the child had pre-existing seizures or behavioral health diagnoses or were deaf or blind. We excluded kids who had actual physical developmental delay or criteria of dysmorphic features or an actual diagnosed genetic syndrome, because we really wanted Canvas to represent the children who were typical looking, phenotypically those children who one would be concerned about autism. When you looked at the demographics of the study completers versus the US Census, the children in the Canvas DX pivotal study were broadly representative of the US population in terms of race and ethnicity and socioeconomic background. So when you broke down race and ethnicity, the kids in the Canvas DX study really mirrored the population in the United States. This is a really important point because we know that the ADOS and the ADIR and many of the tools were actually research tools that were studied on primarily young white male boys. So how does that translate when you've got a child of color or a child from a different ethnicity or a racial background or a girl? So it was really good that in this study, we had that race and ethnicity background that reflected who was in the United States. Interestingly, the educational attainment breakdown showed that the families in the Canvas DX study had, on average, higher educational attainment than people in the United States. But conversely, their family income was less than average in the United States. And that represents the reality for many of our families who have kids with developmental disabilities. You often have to have one parent out of the workforce to take care of that child. The pivotal study results, the primary endpoints were achieved. So the positive predictive value was at 81%, greater than that 65%. The negative predictive value was 98%. And then the indeterminate output was 68%. So 1 in 3 children got a determinate output, a positive or a negative for autism. The secondary endpoints were also met. So the sensitivity and specificity were measured with a sensitivity of 98% and a specificity of 79%. How about those kids in that indeterminate platform? I was going to circle back to why indeterminate is actually very useful in the primary care space. What we found in the study is that of those 68% of kids, 91% of them actually had a neurodevelopmental diagnosis. As it turned out, 20% of those kids actually did have autism, but there were many other diagnoses, everything from global developmental delay to intellectual disability to selective mutism to anxiety disorder that became part of what we saw through there. Why is this important? This is important because traditionally, what would happen in the primary care office is that that pediatrician would have 5 to 10 minutes with that child, and the parent would say, I'm concerned about my child's development. If the pediatrician or primary care provider or nurse practitioner saw something that was concerning to them, that child would be referred on to a developmental specialist. If nothing was seen in that 5 to 10 minutes, often what parents would get would be, well, let's wait a little while. I don't really see anything wrong. Let's go ahead. And as it turns out, these are the kids who wind up in that indeterminate pathway. So it really gives us a very clear, actionable next step, even though that determination was not positive or negative. Because what we are looking at here is as Canvas DX becomes integrated into the primary care practice, it could enable more efficient and informed care planning. Canvas DX would go into the workflow of a primary care practice, somewhat like ordering an X-ray. So you're concerned about something with a child, you order an X-ray, you get an X-ray report back, and then you sit down with the family and you use the information from your clinical suspicion as well as the X-ray to make a diagnosis. Very similar with Canvas DX, that you have a concern, you prescribe Canvas DX, you get an output, and that output along with your knowledge of the family and your knowledge of the child can allow you to sit down and go through next steps with them. So that child who's negative for autism spectrum disorder, autism is ruled out with these children. And what you would do with that family is talk about what your next steps are. If it was a child, for example, who might have an expressive speech delay, well, you get them into speech therapy. If it's a child that you think may have a primary behavioral health disability, you get them into some mental health resources. If it's a child where they have a sibling with autism and parents are just concerned and the child is typical, you watch and monitor closely. What if that child has autism? By Canvas DX, then you streamline that pathway to services. At this point, a primary care clinician can write for speech therapy or occupational therapy. They can put in an authorization for ABA therapy. Some of what we're working on right now is that connection between the diagnosis and getting services, because it's not linear regardless of who makes that diagnosis. But you can start there. The other thing that primary care clinicians know is they know their local early intervention system and they know their local school systems. And many of them take care of kids who are in that early childhood special education program. So the advantage of having a child diagnosed in the primary care center is that these physicians and clinicians know the local resources and then can follow up with these families to make sure they were connected to these resources and that the kids get the care that they need. What about those indeterminate kids? These are the kids that you will have to refer on to a specialist because you don't have a specific diagnosis. In some ways, that's a safety feature. In some ways, that's actually good because not everybody with a developmental delay has autism. But it's really a good thing to be able to say, you know, we need to go on and have further testing for your child. But at the same time, if that parent is concerned about their child's speech, you could get them into speech therapy. If they're concerned about some sensory issues, maybe some occupational therapy. And think again that these are the kids that traditionally have been told, well, let's watch and wait and see. These kids are still going to be getting services earlier because of that indeterminate output. So Canvas DX has the potential to help primary care clinicians effectively diagnose or rule out autism spectrum disorder when used in conjunction with what they know about that child and family, the clinical assessment, so that intervention can be initiated earlier than the current average age of diagnosis. And with that, I'm going to end my formal presentation and ask for questions.
Thanks, Colleen. One quick question. So since there's an indeterminate readout 68% of the time, how does billing occur? So are all families billed for using the system, or is it only if a positive or negative readout will the parent be charged?
So the idea is that Canvas DX would be prescribed and would be covered or not covered as a diagnostic test by an insurance company. So, again, using the X-ray as an example.
Is it a diagnostic test or is it a screening tool?
As a diagnostic test. So a diagnostic aid. So, like an X-ray, you shoot an X-ray on a patient, you might get a negative result, but that tells you something. So even with the indeterminate output, it's important to know, because indeterminate is not negative. We know that 91% of those indeterminate kids have something. So it does give some actionable information at the primary care level.
Okay. All right. Well, thanks for your time. I don't think there's any other questions that have come through, but it was a wonderful presentation. So thank you.
Thank you. Appreciate the opportunity.
Take care. All right. Bye-bye.
Thank you very much, John.